and welcome to another episode of the Clinical Podcast Series. Today, we're actually here at Academy Live, recording this podcast. I'm Andrew Pucker. I am the Executive Director of Clinical and Medical Science at Lexitas Pharma Services, and today I'm here with Kaleb Abbott. Kaleb, could you please introduce yourself?
Yeah, my name is Kaleb Abbott. I'm an optometrist and assistant professor at the University of Colorado School of Medicine. I practice in our dry eye clinic and our Center for Ocular Inflammation, where I specialize in complex and advanced ocular surface disease.
Cool. Well, Kaleb's here today to talk about an article that he actually wrote. So we have the world's expert on this topic, and that paper is called Treatment of Ocular Surface Disease in Ocular Cicatricial Pemphigoid. So that's a mouthful, but could you kind of explain the condition to us and just why it'd be important for optometrists to know about it?
Of course. So mucous membrane pemphigoid is a rare systemic autoimmune condition that attacks mucous membranes throughout the body, predominantly the mouth, but then it can also attack the conjunctiva of the eyes as well. And when it attacks the eyes, then we call it ocular cicatricial pemphigoid. This affects approximately 1 out of 60,000 people, so it's quite rare, but it wreaks absolute havoc on the ocular surface in these patients because it really starts with scarring of the conjunctiva, then leads to fornix shortening. Then after that, you can develop a symblepharon, so fusion between the eyelid and the bulbar conjunctiva. And then the end stage condition, you actually see fusion between the upper lid and the lower lid, so the eyes can actually fully close and you can get severe ocular surface keratinization.
So this is a systemic condition, and it sounds like patients may be bouncing around from different providers, maybe immunology, optometrists, ophthalmologists, who knows, they may be going anywhere. So how long does it typically take for a patient to get an actual diagnosis for this condition?
Yeah, that's the difficult thing. So the early changes to the conjunctiva are so subtle that it's very hard to pick up on some of that early fibrosis. But then as you start to get more scarring of the conjunctiva, it starts to affect tear film distribution and induce dry eye and discomfort. So these patients become symptomatic. But then you end up having to have a provider that kind of understands the condition, that is able to pick up on some of these changes to the conjunctiva, and then actually order a biopsy of the conjunctiva to diagnose it. So in our study, the time between symptom onset of dry eye and actual diagnosis of ocular cicatricial pemphigoid was 4.2 years, but that ranged from 0 to 22 years.
22 years, that's incredible. Like,
yes.
Can you imagine going through probably more than half of your life at your current age, just not knowing what's going on?
Yeah, and in these patients, the ocular surface disease can be yield very, very severe symptoms in these patients. A lot of times they're having, tearing, dryness, grittiness. Their eyelids can, develop an entropion. There's lots of trichiasis involved because it's just pulling the eyelids towards the globe. So these patients can be quite miserable. So you really want to get an early diagnosis to help them out.
Okay, so you did this study. Tell us about kind of the patients and how you found them.
Yeah, so this was a retrospective analysis, and at the University of Colorado, I actually do a dual clinic with our uveitis specialist and then myself in the dry eye clinic. And the uveitis specialist managed the systemic immunomodulatory therapy for the ROCP patients. Then I manage the ocular discomfort and the associated dry eye. So we did a retrospective analysis looking at all of our patients with confirmed OCP that we were seeing, and we had to have seen them at least 6 months to really know what treatments were working and not working. Then we looked at their ocular surface disease, all the treatments that were tried, all the treatments that were failed, so the treatments that were continued, and then the treatments that were discontinued. And we were trying to understand why were certain treatments discontinued in these cases, and which therapies seemed to be effective based on the patients wanting to continue them.
So when reading your paper, I saw something that I hadn't really heard of before called the Foster staging system. Could you give us just a little overview of that? So if we have a patient come in, we can get the right stage so they can maybe get the right treatment?
Yeah, so we analyzed our patients' treatments tried based off the Foster staging system, but there's really 2 ways to analyze severity of OCP. You can either look at the degree of fornix shortening as measured in millimeters, or you can use the Foster system. The Foster system is really a clinical description of what's happening to the conjunctiva. So stage 1 is just some fibrosis or scarring of the conjunctiva. Stage 2 is when the fornix actually starts to shorten up. And you can tell this with patients when you go to pull down their eyelids and it physically doesn't pull. Like it's kind of stuck there and there's not much space between the palpebral conj and the globe. Then stage 3 is when you actually get that symblepharon formation, so the fusion between the bulbar conjunctiva and the eyelid. And stage 4 is kind of end stage where the eyelids are kind of fusing shut.
It sounds like there's a variety of symptoms, and I think one of your patients essentially had persistent corneal epithelial defects as well, if I'm remembering right, so they can even look like maybe an NK patient, right?
Yes, some of these patients can develop NK, some can develop limbal stem cell deficiency. There's mostly you get all these eyelid problems with it though, just because of that scarring changes the anatomy of the eye. So I'd say most commonly we're seeing things like trichiasis, and we're trying to figure out why does this patient have trichiasis, and then we realize that they have OCP. But it's pretty common for these patients to need eyelid repair.
Okay, so one of, I think, the biggest things of your study was just kind of looking at what are doctors doing to make their treatment plans. So what did you kind of find? What treatments are they using? Is there any kind of correlation with the stages of the disease? Yeah, so in general, we found that these patients have more dry eye than the average dry eye patient, which makes sense. 100% of our patients were having to use at least one treatment, and 83% of our patients were having to use prescription treatments for their ocular surface disease. On average, our patients were using 3.33 treatments, 1.7 of which were prescription. Topical immunomodulators were the most discontinued treatment in our study with a discontinuation rate of 73%. So, and this is for a variety of reasons, but the number one was just lack of therapeutic effect. These patients required more than just a topical immunomodulator to control their symptoms. The most effective treatments, as measured by the fact that they were continued by the patients, was autologous serum eye drops and topical corticosteroids. But many of these patients ended up requiring things like amniotic membranes, chronic use of bandaged contact lenses because those eyelashes keep hitting the ocular surface. And then a few of the patients had used scleral contact lenses. But sclerals are difficult in these patients because you're starting to get the fusion between the eyelid and the conjunctiva. It's hard to put a scleral lens in the eye. So some of these patients just physically you couldn't fit it inside the eye. But the patients that could use sclerals, it actually worked quite well. I found that interesting in your paper. I think you noted that graft-versus-host disease commonly uses sclerals, but maybe not a good choice in this specific patient group.
Yeah, just there's too many anatomical changes to the surface that presents a lot of challenges with fitting sclerals. But then what we did next in the study was we actually looked at the treatments tried, the number of prescriptions, treatments that these patients had used, the number of procedures that they underwent based off the Foster staging system severity. What we found that is stage 1 and stage 2, they utilized much less treatments to control their dry eye, but it sharply rose at stage 3. So with stage 3, all of a sudden we found that patients were having to use many more prescription medications, more procedures, and that was kind of indicative of more ocular surface disease and more symptomatic patient.
That sounds great. So say we have someone watching this podcast, they learn all about this condition, and they're the first doctor to diagnose someone with pemphigoid. So what should they be thinking about? Who should they be referring to? What doctors they should be referring to? What maybe medications would you recommend overall for them?
Yeah, initially you have to make sure that they get a biopsy to try to confirm OCP. However, the false negative rate is high for these, so sometimes it comes back negative, but you still assume that it's positive. So you generally have to get either a rheumatologist or a uveitis specialist involved because they're going to be the ones that are controlling the systemic immunomodulatory therapy. And it's really that therapy and that treatment that's what's slowing the disease progression. There's nothing that we do as eye care providers topically for these patients and to try to help their comfort that actually slows down disease progression. So you have to get them to a rheumatologist or a uveitis specialist who's going to be managing all of that. And then they need to be seeing a dry eye specialist, an optometrist or an ophthalmologist to help manage their discomfort because these patients are in quite a bit of discomfort. And then ideally you really want to have an oculoplastics provider too because I'd say many of these patients end up needing to have some sort of an eyelid surgery.
I think that's a great message. So we should be thinking holistically and really tapping into every resource that they could potentially have. So with that, any closing thoughts, anything you want to leave our listeners with before we close out?
Yeah, I just think OCP is an example of a condition that providers really have to have a different approach to their dry eye treatments and their ocular surface disease treatments. You have to be much more aggressive initially to try to control these patients' symptoms. And we need to understand that the anatomy of the ocular surface plays a big deal in terms of our treatment of dry eye and how symptomatic our patients are.
Cool. Well, I'd like to thank you, Kaleb, for being here today.
Of course. Thank you for having me.
And I'd like to thank you all for tuning into this podcast. I'd just like to ask you to like, subscribe, and tell 10 people about us. And we hope to see you again on another podcast soon.